I'm Jazz, and it's great to be part of this virtual teaching and to be able to share some of the research within my PhD at La Trobe University and in collaboration with the University of Technology, Sydney. Congratulations to the team at Aphasia Access for this project. I'll minimize myself so you can concentrate on the presentation. This research is situated within stroke rehabilitation with the focus on speech pathologist counselling practice for supporting psychological well-being in people affected by aphasia after stroke. Speech pathologists are important members of the stroke team because aphasia, a language disorder, requires speech pathology assessment and management. Stroke is possible function and participation with the best possible quality of life. The Aphasia Framework of Outcome Measures, or AFROM, is a user-friendly framework for goal planning and outcomes adapted from the World Health Organization's Framework of Functioning Disability and Health and is used in aphasia rehabilitation. Client goals are represented across all domains of the ICF and AFROM with the aim of optimal participation in life. People with aphasia experience a range of psychological issues after stroke and are particularly vulnerable to mood disorders such as anxiety and depression. Addressing psychological well-being is important in stroke and aphasia rehabilitation because psychological issues negatively impact stroke rehabilitation outcomes, including participation in rehabilitation, quality of life, and mortality. Speech pathologists working in post-stroke aphasia believed they have a role to play in supporting psychological well-being in aphasia rehabilitation. Professional guidelines state counselling is a clinical service within the scope of speech pathology practice, with referrals to other professionals as required. Clients include the individual with the communication or swallowing disorder, family members, and any significant others. Parkinson and Ray define counselling to be a dynamic process based on the therapeutic relationship that underlies all clinical service activities. They suggested that counselling includes all verbal and non-verbal interactions and requires the clinician to have an ongoing awareness and sensitivity to the client's feelings, thoughts, and behaviors, their own feelings, thoughts, and behaviors, what is happening between in the here and now, and outside events which may be influencing the therapeutic space. Counselling aims to help clients deal with their specific need or problem and to help them progress towards their goals. Counselling processes may include explaining the nature, assessment, and treatment of the problem, and using approaches such as a patient-centered approach to help clients adjust to and cope with thoughts, attitudes, feelings, and problems related to the communication disorder. At entry level to the profession, speech pathologists are expected to have excellent and effective communication, counselling, and interpersonal skills. Psychological well-being is about lives going well. It is the combination of feeling good and functioning effectively. Psychological well-being is a dynamic state in which the individual can develop their potential, work productively and creatively, build positive relationships, and contribute to their community. It is enhanced when an individual can fulfill their personal and social goals and achieve a sense of purpose in society. Psychological well-being is intimately linked to mental capital. Mental capital encompasses a person's cognitive and emotional resources. It includes their cognitive ability and their emotional intelligence, such as their social skills and resilience in the face of stress. Addressing psychological well-being will affect mental resources and vice versa. 2 surveys of aphasia rehabilitation practice in Australia found that speech pathologists reported to frequently use a range of clinical and counselling approaches to support the psychological well-being of their clients. But they reported low knowledge, low confidence, and low satisfaction in counselling skills and for assessing and managing psychological well-being in this population. Clinicians wanted more training to meet this role and responsibility. In the United Kingdom, a stepped model for psychological care provides a framework for the assessment and management of emotional conditions and cognitive conditions after stroke. The stepped care model also provides a framework for the stroke multidisciplinary team in terms of their responsibilities and extent of psychological support or counselling they may provide. Psychological support at level 1 and 2, which may support psychological well-being and prevent mood disorders, relevant to speech pathologists, include a range of clinical, counselling, and brief psychological approaches. However, it is recommended that psychological interventions are used by staff with appropriate training and competency at each level. We wanted to investigate if there's a relationship between appropriate training and speech pathologists feeling confident, skilled, and competent to provide psychological care in their work in aphasia after stroke. Our systematic review investigated what counselling training speech pathologists received to enable them to support psychological well-being in post-stroke aphasia. Specifically, we sought to find information about the content, methods, amount, and evaluations of counselling training. 9 studies were included, 4 studies from America describing pre-qualification training, and 5 studies from Australia and the UK describing post-qualification counselling training. Topics offered to American speech pathology students included general and specific counselling training, goal setting, and training in client-centered and holistic approaches. Training processes included observation, coursework, practicum, and group learning with other disciplines, for example, social work. Hours of counselling training was unclear, but 3 to 4 hours was reported. A recent paper by Dode, Hoepner, and Holland provides an update on counselling training in communication disorders in American universities. Relevant topic areas to counselling in post-stroke aphasia include the role of speech pathologists in counselling, counselling fundamentals, interprofessional practice, psychosocial adjustment, educational counselling, working with families and disorder-specific counselling. Training addressed knowledge and implementation skills, self-reflection, and assessment, and was delivered through coursework and embedded programs. A majority of courses provided between 3 to 4 hours of training and So overall, we found that counseling training and experience was positively correlated with comfort and preparedness to counsel clients and carers. After qualifications, some British speech pathologists working in stroke care received level 1 training. Some speech pathologists also sought training from external sources. Speech pathologists reported a range of counseling training from none to PhD qualifications. Commonly, training was between 1 to 2 days. Adult learning principles and viewing videos of counseling techniques were used. Speech pathologists with counseling training of a day or more were 4 times more likely to report feeling knowledgeable, skilled, and confident to address psychological well-being in post-stroke aphasia when compared to speech pathologists without training. We found no information about pre-qualification counseling training from Australian universities, and it was difficult to pinpoint what training exactly affects speech pathologists' confidence and competence. For the next study, we devised a survey based on the 4 American studies. Our survey comprised of 16 closed questions and 2 open-ended questions. 3 universities in New Zealand were asked to pilot the survey. 1 university participated and provided feedback for clearer logic and definition of counseling, which was incorporated into the survey. An invitation to participate in an online survey was sent to the 15 universities offering 21 speech pathology courses. 1 survey response was required, and the survey was open for 4 weeks. 12 survey responses were received out of 21 courses, which gave us a 57% response rate. Responses were received from all states where speech pathology courses were provided. All courses trained speech pathology students to work with people affected by post-stroke aphasia. Most provided counseling training for working as a speech pathologist, but few provided counseling training for working in post-stroke aphasia. A variety of counseling topics was selected, and the most common topic was general principles of counseling. Specific approaches taught as listed in the free text box to this question included micro skills, motivational interviewing, cognitive behavioral therapy, and coaching. A range of methods of counseling training were selected, with use of role play and case discussion most frequently reported. Other popular methods include use of didactic lectures and group discussions, and watching videos of counseling techniques. Counseling training was evaluated by written assignment, review of videoed and written transcripts of role play, oral assignment, and problem-based learning. For counseling skills relevant to speech pathology work, a majority of courses provided over 10 hours of coursework and 3 hours or less of counseling practicum and observation. For counseling specific to working in post-stroke aphasia, a majority of universities provided 3 hours or less of training. All academics except 1 considered counseling training essential to speech pathology qualifications. However, only 3 felt that students were competent in providing counseling to people affected by post-stroke aphasia. In conclusion, although counseling is believed to be essential to speech pathology practice, some universities in Australia do not teach these skills. It is likely that many speech pathologists qualify with little skills or competency for counseling in post-stroke aphasia. There are limitations. Although we had close to 60% response rate, a responder bias does limit generalization of these results. We investigated counseling training delivered within the university only and acknowledged that students may receive some training while on clinical placement. The quantity and quality of counselling training in clinical placements external to the university does require investigation. The next study aims to evaluate the effect of a training module on speech pathologists' self-efficacy and self-reported competency for counselling in post-stroke aphasia. Information gleaned from our systematic review and the survey study will inform the training module. The content, the counselling training module will include these areas. The content, and this slide describes the content, the processes and approaches that we will use in this training module. This phase 2 pilot study will use a randomized control design with a waitlist control condition. A convenience sample of 40 eligible speech pathologists from Australia will be recruited. Stratification of previous counselling or psychological training and usual co-counselling practice with mental health professionals will control for these potentially potent variables. The counselling training module will be delivered online and will include approximately 4 hours of prescribed learning and 4 hours of online workshops. 2 outcome surveys will collect data at 3 time points for Group A and 4 time points for Group B using online surveys via the Qualtrics platform. Data will be analysed using t-tests to compare mean scores. Effect size and standard deviations will be reported. The primary outcome measures is the self-efficacy measurement tool for counselling in speech pathology by Victorino and Hinkle. Self-efficacy, a construct defined by Albert Bandura, is the perception one has about his or her skills and the confidence to employ these abilities with success. It is a psychometrically sound tool which was validated or the tool that we are using is a psychometrically sound tool, which was validated on graduate speech pathology students and early career speech pathologists. The secondary outcome measure is a checklist of counselling skills for working in post-stroke aphasia developed by us specifically for this study. It includes 8 closed questions which explore possible counselling skills relevant to post-stroke aphasia. Clinicians will be asked to rate their confidence to recognize and respond to anxiety, depression, and suicide ideation, to manage the psychological well-being of self and colleagues, and to use a problem-solving approach and a person-centered approach. The final question asks clinicians to rate their own competency for counseling people affected by post-stroke aphasia as part of their speech pathology role. Both measures ask participants to rate their perceived confidence in using a counseling skill on a 6-point ranked scale. Ultimately, stroke and aphasia rehabilitation aims to enable the individual to live their best life possible. The effectiveness of speech pathologists' counselling practice on client outcomes in post-stroke aphasia is certainly required. This research addresses the known barriers to speech pathology counselling, including limited skills and time. Further evaluations of what helps or hinders translation of this research into clinical practice would be valuable. Here are the references to this presentation. And thank you again for this opportunity to present our research in this forum. Please feel free to email me if you have any comments or questions. And again, thank you.